We are
Hello, good evening, everyone. I welcome you all to the second episode of Guru Sangam, an initiative of the All India Ophthalmological Society to bring together teachers who will not only impart us knowledge, but help the students to develop a deep understanding of the subject that the teachers will be covering in depth. So, Guru Sangam is a brainchild of our president, Dr. Harbans Lal, and it has been executed with inputs from Dr. Santosh Honavar. And I thank both of them for their initiative. I'm sure this will prove to be a very useful and informative and educational experience, especially for our postgraduate students, because every subject that is being covered by the teachers is going to be very exhaustive, and they're going to be discussing the finer details of the subject. So, our distinguished teachers, each is a luminary in their respective area of specialization, and they will guide you through a spectrum of topics. And I hope that this webinar proves to be a very informative and illuminating one for everyone. I'd like to emphasize that the webinar is not just a platform for learning, but it is also an opportunity for dialogue and interaction. So I request all the audience, especially our postgraduate students who have logged in, to make full use of this opportunity. Feel free to share your questions, doubts, perspectives, any comments in the chat box. So please keep the questions coming, which we'll take at the end of the talk. And I thank all the speakers who have joined us here. I thank everyone for being a part of this educational endeavor. And I'm sure it's going to be a very useful 3 hours. So let's start the learning. With this, I invite our first speaker, Dr. Madhuri Venigala, who is a consultant, cornea and anterior segment at the Sankara Eye Hospital, Guntur, an alumnus of the Guntur Medical College and fellowship trained in cornea and anterior segment from the Sankara Eye Hospital, Guntur. She went on to join there as a consultant in 2017 and has been there since as a faculty who is very actively involved in teaching, publications, and presentations alike. So I welcome Dr. Madhuri Venigala and I invite her to speak on her subject of choice, corneal ectasia. Over to you, Dr. Madhuri.
Thank you, ma'am, for the nice introduction. At the outset, I thank AIOS GuruSangam for giving me this opportunity. Thanks to the President, Mr. Harbans Lal sir, and our moderators for today, Dr. Santosh Honavar sir, and Tinku Bali madam, and all AIOS members. It's a vast topic which I'll try to get through it very briefly. So what do you mean by ectasia? The meaning of ectatic means the distension or dilatation of a duct, vessel, or hollow viscus. Now, how do you attribute this to a cornea? So corneal ectasias is a group of diseases affecting the corneal shape due to corneal thinning. The most common which we come across are the anterior keratoconus, keratoglobus, pellucid marginal degeneration, posterior keratoconus, corneal ectasia post-refractive surgery or post-trauma. Usually they are bilateral, often asymmetrical and isolated to cornea, non-inflammatory. And why is the cornea ectatic? If you look at the cornea, it's a complex viscoelastic structure having very least resistance to any applied force, but still it maintains its contour and biomechanical architecture. It is a structural integrity, specifically the collagen fibrils, the collagen crosslinks, and rigid anterior lamellae, which provides a biomechanical strength. So the corneal tissue is under constant intraocular pressure, which pushes on the back surface of the cornea to physically balance the atmospheric pressure from the outside. A normal healthy cornea easily withstands the forces applied on it and maintains its shape. Any dissociation between the applied forces, that is intraocular pressure and atmospheric pressure, and the biomechanical weakening of corneal tissue, the intraocular force would lead to protrusion, bulging, and finally keratoectasia. Forces act to the posterior surface of the cornea, so the ectatic changes first would appear on the posterior surface of the cornea. There are hundreds of reasons for the biomechanical weakening of the cornea, but the primary risk factors which may cause biomechanical weakening include the inherent keratoconus, low corneal hysteresis, pellucid marginal degeneration, formed frusty keratoconus, thin corneas with less than 500 microns, and post-classic corneas with residual stroma blood less than 250 microns. So the importance of ectasia is it is easy to miss in the early stages, and they can be prevented from progressing if diagnosed early. The contraindication, they are all for corneal-based refractive surgery. So the most common thing which we going to have a little elaborately today is about the keratoconus, which is a progressive corneal steepening, typically inferior to the center of the cornea, usually non-inflammatory and bilateral. The incidence is around 50 and 230 per 1 lakh population. Unilateral in around 2 to 4%, and the onset starts at the age of puberty. The associated diseases, there can be a number of diseases, usually systemic associations with atopy, Down syndrome, any connective tissue diseases like Ehlers-Danlos, Marfan syndrome, and ocular conditions like vernal conjunctivitis, retinitis pigmentosa, Leber's congenital amaurosis, ROP, and Fuchs dystrophy. How we can attribute the etiology? Biochemically, there is upregulation of the degradative enzymes like acid esterases, acid phosphatases, matrix metalloproteinases, and the downregulation of the protease inhibitors. So this causes a fourfold increase in the receptors of interleukin-1, causing apoptosis of the stromal keratocytes. Any microtrauma in the form of eye rubbing or any trivial trauma increases the release of this interleukin-1 and interleukin-6 from the corneal epithelium. And it is an autosomal dominant inheritance with incomplete penetrance, and the frequency is around 6%. The pathology the keratoconus can involve every layer and tissue of the cornea. Superficial cell enlargement and prominence of elongated cells in the corneal epithelium causes early degeneration of the basal epithelial cells, causing disruption of the epithelial basement membrane. So the epithelium grows posterior into the Bowman's layer with collagen growing anterior into the epithelium. There will be jet shapes, interruptions in the layer of the basement membrane, and causing the fragmentation of the Bowman's layer. The Fleischer's ring will be found at the base of the cone. It's a hallmark of keratoconus. The breaks in Bowman's layer fill with scar tissue, and fine scars consolidate, leading to the formation of branched opacities at this level. So collagen lamella are released from the interlamellar attachments or from the attachments in the Bowman's membrane, and they become free to slide, and they cause thinning without collagenolysis. There will be alteration of the normal orthogonal arrangement of the collagen fibrils, leading to stromal tissue instability. The most common location will be at the apex of the cornea, either in the center or inferior cornea. So diagnosis, usually the onset is at puberty. It usually appears in the second or third decade. The symptoms can be progressive visual blurring and distortion due to irregular astigmatism. There can be frequent change of glasses. Sometimes there can be associated pain and photophobia, and constant eye rubbing can be an instigating factor. If you go to the signs coming from the anterior segment, there can be in the lids papillae, giant cobblestone papillae, can be Trantas dots at the limbal nodules, pigmentation, thropy discharge. So the corneal ectasia, usually the apex is inferior to the horizontal line to the pupillary axis, and corneal thinning is around 1/2 to 1/5 is observed at the apex, and there can be types of cones like round or nipple-shaped cones and oval-shaped cones. The earlier signs which are diagnostic, you can see on retinoscopy, the scissoring of the reflex, and the Fleischer's ring will be seen the iron deposits at the base of the cone in the epithelium. The ring configuration is due to irregular distribution of tears at the base of the cone, the resultant hemosiderin deposition. There can be prominent corneal nerves. And as the disease progresses in the late signs, there appears some signs like Munson sign, which is bulging of the lower lid in the down gaze. There can be Ricci's phenomenon, where when we show there will be appearance of prominence of the cone on the nasal side when the torchlight is shown from the temporal side. There can be Chorlach sign like dark reflex in the area of the cone, observation of the cornea with pupil dilated using a direct ophthalmoscope. It can be oil droplet sign, and which appear still more later are the warped striae, which are fine vertical lines formed due to compression of the Descemet's membrane. They are seen parallel to the axis of the cone. And at any stage, there can be corneal thinning and scarring. And there's a condition like acute hydrops, which occurs due to break in the Descemet membrane and causing stromal edema, causing diffuse edema, pain, and photophobia of the patient. And at this stage, the use of anti-glaucoma medications and hypertonic drops. And if we have to differentiate this with the common differential diagnosis of all this, like PMD, keratoglobus, post-traumatic ectasia, or protrusion subsequent from thinning from ulceration, or corneal ectasia following any refractive surgery. There are different classifications. Like this is one ABCD criteria based on the anterior and posterior radius of curvature of the cornea and the scarring. And morphologically, we can classify as common classification as a nipple cone, oval cone. Nipple is less than 5 millimeter in diameter, which is can be central or paracentral, most commonly inferonasal, and it can be easily corrected with contact lens. The oval cone is around more than 5 millimeter diameter, usually paracentral and peripheral, more common infranasal, and correction with lens is difficult. And keratoglobus, it is total located throughout 75% of the cornea. Correction with contact lens is difficult. The common Amsler-Tumich classification, where it is based on more of eccentric steepening, K readings, myopia and astigmatism less than 5 diopters, with mean central K reading less than 48 is stage 1, and less than 53 is stage 2. Stage 3 goes to K readings more than 53 and thickness, cornea thickness from 300 to 400 microns. And stage 4, where the refraction is not measurable and mean central K readings are more steep, more than 55 with central scarring, and minimal corneal thickness goes to 200 microns. So how do we go for the investigations? Most commonly, we have to go for the keratometry, where the mires are commonly steep, highly astigmatic, often oval-shaped or egg-shaped, and is inability to superimpose the central keratometric rings. And limitation is it provides only central 3 millimeters of cornea, so it's not used in irregular astigmatisms. To overcome that, there are many diagnostic tools nowadays, which are based on video keratometry, which is based on Placido disc principle. In the early disease, isolated area of smaller ring spacing will be seen between the rings and distortion. In advanced disease, there will be decrease in overall ring spacing and becomes increasingly irregular. Again, the limitation is it does not give accurate information about the posterior curvature and cannot detect early keratoconus. To overcome that, the latest thing is OpScan, which uses the principle of scanning slit combined with the Placido system. It provides reliable information about the anterior and posterior elevation and best fits peer and a corneal pachymetry map. And the limitation is the pachymetry, the posterior curvature may not be 100% accurate and requires patient fixation. And based on this, there will be Rabinowitz criteria, which is a common criteria where K more than 47.2 and inferior superior asymmetry more than 1.2 to 1.4 diopter, the Kisa index more than 60%, and the skewing of radial axis more than 21 degrees. All the other criteria for the establishment of keratoconus. Now, the progression of the astigmatism on the OpScan can be symmetric bow tie pattern going to asymmetric appearance, and they going to inferotemporally displaced steep-sided cone, can be symmetric bow tie, asymmetric with skewed radial axis or inferior steepening. And the next modality is a pentacam, where it uses a rotating Scheimpflug camera. It provides reliable data of both the anterior and posterior elevations and accurate measurement of corneal thickness. The images taken by pentacam maintain the central point of each meridian. Hence, the software can re-register the central points and eliminate the eye movement. And data is 10 times more accurate than obtained from OpScan. The pachymetry can be measured using ultrasonic and optical-based devices. A measurement thickness is useful for diagnosis, for documenting progression and planning the treatment. And based on the corneal hysteresis, the recent one is ocular response analyzer. It helps in making a diagnosis and classifying. Now, the treatment options. There can be both non-surgical and surgical. Non-surgical spectacles only in the early cases. Once irregular astigmatism develops, this type of visual correction cannot be used. And contact lenses can be used to treat. To some extent, there can be a wide range of soft toric lenses or standard bicurved hard lenses, custom back torics, piggyback lenses, hybrid lenses, scleral lenses, and mini scleral lenses. The most common first choice in correcting irregular astigmatism are the rigid gas permeable lenses. The RGP lenses, the apical clearance will be, they should not touch in the apical area. The fitting strategies differ from case to case. Advantage is reduce the risk of scarring and corneal erosions. And limitation being edge can come in visual axis and hampers tear exchange, rarely used nowadays. The RGP lens advantage is it gives better quality of vision. The central optic zone of the lens touches the central cornea. The limitation being corneal scarring intolerance over long term, and in that the 3-point touch is most popular technique. The lens bearing is shared between the apex and mid-peripheral cornea. In the other one is a piggyback lens, where it consists of fitting a rigid gas lens, RGP lens on top of a soft contact lens. The soft contact lens is used to improve the comfort and provide a more regular surface, and for that RGP can be used. The other kind is a hybrid contact lens, where it contains a rigid gas permeable center with a soft skirting. They are fitted with no or minimal apical touch in the central cornea. So the advantage is they can be fit on cones of any severity, whereas they are limited because they cause hypoxia-related changes like vascularization and central corneal clouding. The next comes the Rosque lenses. They are multi-curve lenses with small optic zone, which fits snugly over the cone. They provide greater comfort and better quality of vision. And it is a large diameter intralimbal lens that can be used over oval cones. That is a Rosque to IC. Next comes the scleral lens, the rest on the sclera without touching the